And what we've got lined up for you today on the next slide, our programme is, first of all, Becky James from the Office for Health Improvement and Disparities. Have I got that right? I think I have. We'll introduce some principles, some working principles to do with working with people, and explain where those have come from and how they might be used. And then the main part of the session is a couple of examples from our region. Ange Broadbridge from Waste to Wellness will talk about the way that they engage with people in their maternal mental health program. And after that, Lorna Dawson from Sunderland and South Shields Foundation Healthcare Trust, I might have that right, we'll talk about the work that they do on health literacy, because they're leading the work on health literacy for the Healthier and Fairer programme, and talk about how they engage with the public and involve them in their work. And then I'll wrap up at the end with some resources and kind of next steps. So that's what we've got lined up, and we'll try to make sure that you have time for questions. And if you need to take a break to take care of your own needs, then please do so. Don't feel the need to ask or tell anyone. Just do what you need to look after yourself. There are no scheduled breaks in this session. Okay, let's move on and hear from Becky James about these working with people principles.
Yeah, hi everybody. So as Richard said, my name is Becky James. I'm a Health and Wellbeing Programme Manager for the Office of Health Improvement and Disparities in the North East. So I have a regional role around health inequalities and around healthy communities. And I do quite a bit of work working with VONNE around supporting regional pieces of work around things like this. So I've got a couple of intro slides just to show where this work and this webinar series sits. So if we move on to the next slide. So this is just a very kind of simple structure around the Healthier and Fairer programme. And this is a programme of work and funding across the North East and North Cumbria Integrated Care Board, with a number of priorities and projects all around system working to improve health outcomes for our population. And the bit that we're kind of interested in is that bit at the bottom, which there's 3 cross-cutting work streams, and the bit in the middle is where this work all sits within the healthy communities and social prescribing work stream. And to really champion and support the use of community-centred approaches, and really kind of ensuring that people and communities are at the heart of all of the work that we do across all of this kind of programme of work. We've developed a set of principles that can be used across this programme, across the Healthier and Fairer programme and beyond. And it's part of the work of the group that Richard and I are involved in, the Healthy Communities and Social Prescribing work stream, to really influence all of the work that we're doing across health inequalities and make sure that these principles are embedded as core ways of working. So if we move on to the next slide. So we've tried to pull together this set of principles, and we've, rather than starting from scratch, based them on, people may be familiar with this already, this flower diagram, which comes from the NHS England working in partnership with people and communities statutory guidance. So our principles are very much based on this, and this is all about, as the diagram shows, really putting kind of people and communities right at the centre of all of the work that we do. And the next slide. So the next 2 slides just show our 10 principles. I'm not going to read them all out, and we can share these slides after, so you can look at these in more detail. But really the essence of kind of these, all of these kind of points are about putting people and communities at the heart of our decisions, really understanding what people from our local communities, what their needs are, ensuring that the work that we do across the system is inclusive, that we're really working with our voluntary and community sector organisations and our businesses, really kind of tapping into the assets that we already have. And the next slide. Making sure that the information that we have is clear and easy to access, and actually these principles have been through our kind of health literacy approach, which you're going to hear more about when Lorna talks about her project. That the work that we do kind of empowers people, that we're learning and building from what's already happening and working across the system. So, you know, a lot of the work that we're doing across the Healthier and Fairer programme isn't about sort of starting from scratch. It's about recognising that, again, we have a lot of assets and things that are working really well, and it's about building up from that. So I know that's a really kind of quick whistle stop tour of this work, but you know, it's one thing to kind of develop a set of principles and a kind of list, but actually what we're really keen is about how we put this into practice. So the kind of point of having this webinar is to really hear from some examples of practice. So we're now going to hear from the two projects, you know, two examples of this that are putting these principles into practice and kind of really embedding this into the work. And I'm really keen to hear from you sort of through the chat or through the Q&A at the end about how we can do more to embed these principles throughout our system working through the Healthier and Fairer programme and beyond. So I'll hand over to Ange now, and we're going to hear about the Waste to Wellness project. Thank you.
Thanks. I'm just going to share my slides. If someone could just verbally let me know that you can see these slides, that would be great.
Yeah, we can see them.
Super. Thank you. So I'm Ange Broadbridge. I'm Maternal Mental Health Services Project Manager at Waste to Wellness. We're an innovation hub working across the North East and North Cumbria. And quite often the kinds of innovation projects we'll get involved with will be around health inequalities, and this Maternal Mental Health Services one is no exception. So just going to start with a little bit of background to what we've been doing over about the last 2 years and why. Talk a bit about our approach to co-production, which we very much see as a golden thread that runs through all that we do. So I really like in Becky's slides that piece around involving people at every stage of the work. That's something that we've really tried to do in this programme of work. I'll talk a bit about our mindset for co-producing. So a bit like the guidelines that Becky shared, we've developed some specific specialised guidelines for this project, but that I think probably would generally fit quite well with other social prescribing projects and social prescribing approaches. And then finally talk a little bit about our learning community approach and our approach to learning, and how that also has been very much an approach that we've co-produced. So just starting with a bit about what we set out to do, we've been setting up social prescribing link worker prototypes in 4 areas of the North East and North Cumbria. It's one-to-one support during pregnancy up to baby's 2nd birthday for mums and mums to be experiencing mild to moderate mental health needs. And the work has been very much set up to be responsive to place-based needs and with a focus on health inequalities. And we were really fortunate with the funding that came through for this work to also have a small pot for developing new peer support opportunities as they were identified by the link workers in the course of working one-to-one with mums in the community. So there were gaps in peer support that we've identified, and we've tried to work with the projects to really try to fill some of those gaps and make sure that we're meeting those local needs. So by way of background, funding for this work came in through a successful bid by North East and North Cumbria Mental Health ICS and the Perinatal Mental Health Clinical Network to NHS England's Maternal Mental Health Fast Follower programme. So at the point where Sunderland and South Tyneside and North Cumbria were piloting new clinical maternal mental health services, we were funded to look at social prescribing link work to work at the more mild to moderate end. So women who wouldn't qualify for a clinical service, but had been identified as having some mild to moderate mental health needs. And we've been prototyping social prescribing as an approach to working with those families. We had some support from VONNE and from Cumbria CVS as we were getting the project off the ground, and we've worked together to disperse funding to 4 VCSE organisations, so Sunderland Counselling Service, Every Turn Mental Health in Northumberland, Mind in Teesside and Together We in North Cumbria, and each of those VCSE organisations hosts a link worker project and has had some associated peer support that sits almost sort of wraps around the project really. So just to talk a little bit about these 5 mindsets for co-production, or sort of guiding principles for co-production, and I think these have guided us well in ensuring that we are actively listening and that we are doing that thing that's about including and involving people at every stage of the work. That has really started with an approach to genuine co-production, so elevating the voice of lived experience, elevating those experiences of mums who have had mental health experiences during the perinatal period at every stage of the project, really actively listening and checking in with each other that we are continually actively listening at each stage of the process. It's about valuing multiple perspectives. So that's about understanding each other's roles. When we set this work up, I think it's probably fair to say that GPs in general practice really have a strong understanding of social prescribing and have been working with social prescribers, and indeed, you know, most primary care networks also have social prescribing in there now. But for this project, our referrals are coming from midwifery, from health visitors, from parts of the health and care system that hadn't been exposed to social prescribing. So part of that co-production was about co-production with other services and kind of understanding each other's roles and using professional curiosity to understand what were the blockers and the kind of barriers and facilitators for mums to be able to take up maternal mental health support. We've been really committed to learning through prototyping. We set this up as like a really rapid test and learn approach. So we had to get the services up quite quickly. And I guess through that meant that rapid test and learn looked like if we started something and we heard from mums that it wasn't working, we stopped doing it, or we pivoted and we made changes to the delivery to make sure that we were really responsive to those communities' needs. And then finally being really action focused, so working through task and finish groups and sprints on really key pieces of work, and then bringing together key contacts from across the local maternity and neonatal system to hear the insights that the link workers have been hearing over the last 18 months of delivery, to make sure that if we do identify barriers and blockages and potential facilitators, that we're sharing those with our local health and care system, because that really kind of active approach is the thing that's going to make a difference and mean that we have the best chance of making changes to services to really be responsive to women and families' needs. So we have this approach of sort of co-production as a golden thread. That little diagram at the bottom there with the kind of black fuzzy line, if you imagine that's a golden thread, what that kind of diagram is about is when we first started this work, I think we were very much at that fuzzy front end that's described here, so that tangled ball of wool. And we've been working together with women and families and with services now to really untangle that, to value all voices and to really kind of work through a model for delivery that's responsive to those needs. We've been doing a range of engagement activities with women and families throughout the lifetime of the project. We started with a really flexible design framework, so that wasn't putting a delivery model in place, a prescriptive model, but very much creating a space for those prototype providers to develop new supports and services informed by local need within a bit of a common sort of delivery framework, but with plenty of flexibility to be really responsive to local needs. We've been seeking regular feedback through a really wide range of mechanisms. One of those mechanisms is the Maternity Voices Partnerships. So each hospital trust hosts a Maternity Voices Partnership, which is a lay partnership of kind of bringing together health professionals together with women who have experience of using maternity services, families who have experience of using maternity services, to really think about how things might need to change to improve services. So very much that quality improvement approach. And we've been really fortunate to have the support from the Maternity Voices Partnerships to really be that critical friend, I guess, as we've been developing this work. We've also been developing new groups that are really responsive to local needs. Our Middlesbrough-based project, the Sakina project, had a kind of an early prototype of some peer support that the women coming together through that network called Chat and Chai. That group was sort of set up around support for women from minoritised ethnic communities and the group and how the group runs was very much co-designed with women. They didn't want that to be called a mental health peer support group. They chose the name for the group and they co-produced and co-designed what that group should look like and how it should run. And our North Northumberland project, I think one of the things that we heard really consistently from women there up in North Northumberland was that, I guess, let alone there being peer support groups, there weren't even mother and baby groups that felt accessible for those women to be able to get to. They were experiencing really high levels of rural isolation. And I guess what we were describing there was a remote experience of parenting, really feeling very, very remote, very isolated. And we'd supported a mum who had been supported by the Linkwork project with a little bit of funding to set up a new group, which is called the Wool Pack, which is Wooler Parents and Kids, and has been coming together quite regularly for almost a year now, bringing in excess of 25 families together during peer support sessions to really be able to offer that responsive peer support and really speak to the needs of rural and isolated women and families. And then the last thing, just touching on a bit around co-production of resources for booking in. So we've been working in North Cumbria with an organisation called Happy Mums, together with Newcastle University's Centre for Digital Citizens, connecting to Maternity Voices partnerships and also to Local Health Watch, working on a couple of creative approaches. And this next slide just presents a couple of the artefacts, I suppose, that have been produced and developed working alongside women and families. So we invited people to come together, people who identify as a mum or a mum-to-be with some experiences of accessing peer or community support, to talk with us about their needs relating to their maternal well-being. It was a really creative approach that was taken to listening and learning and to storytelling. And the artefacts that we have on the screen here are things that the women have created, zines and collages, really talking about their experiences around maternal mental health and how things could be better. And I guess the broader aspiration of that work was to take an inclusive and a creative and a participatory approach to hopefully informing peer support resources for improving the delivery of perinatal care in our region. So I think that opportunity to work alongside Centre for Digital Citizens at Newcastle University and benefit from their expertise in terms of developing and delivering really participatory research approaches has been really valuable. And I think bringing more of the kind of creative piece means that women have worked to develop a range of materials that we feel other women would really benefit from seeing during those booking appointments for maternity. So really keen to see where we take that forward and to be able to share some of those outputs hopefully quite soon with you. And lastly, just to touch a bit on our approach to learning. We bring the link workers together once a month as a learning community, and I guess the purpose of that was very much for the link workers who, within their own organisations, are lone workers, I suppose, in the sense that there's only one of them. There's only one maternal mental health link worker in each of those areas. So bringing them together to be able to look at what are they seeing as kind of trends and themes across their caseload, and triangulating what we're seeing and hearing from families with those link worker insights. We've taken some of the things that we kind of heard both through the learning community and from women and families in the community to co-produce this mosaic of maternal mental health needs. So that's about growing our knowledge, it's about raising awareness, and really crucially about starting conversations. So within this mosaic and the tiles that we have here that cover things like, social capital, number of children, stigma, access to childcare, traumatic experiences, grief, we also have these blank boxes, or these boxes with a question mark, really sort of highlighting that this is just the start of the picture, and we've been working with women and families to grow our understanding. It's a really iterative piece of work, and I've really liked this way of working because we've been able to produce a paper version of this mosaic of maternal mental health factors, take that out into the community and work with women so they can tell us which of these issues are most important to them, and we can kind of tessellate those blocks, I suppose, and put them together and repiece them to look at creating individual stories with women too. So I think that's one of the real benefits of working alongside our academic partners, has been really learning about those creative approaches to research and creative approaches to co-production, and embedding those things within the VCSE to be able to do work that feels really creative and is really supporting mums in their storytelling and making sense, I suppose, of their experiences too. I think one of the things that we've heard really strongly from women is there's this real sense of sort of guilt and stigma, fear around not being a good enough parent. These things feature really heavily in the learning. And then in kind of connecting support and building connections and building women's confidence. And that very much is the link worker role in that sense of what matters to me, seeing women work alongside the link worker to co-produce their outcomes. And then the last slide I wanted to share just sort of builds on that a little bit more to talk about co-production leading to integration. So I have a quote here from a midwife who's referred into the service, just thinking about how that co-production really leads us to integrating with clinical services. So she's saying here, we might set up a joint treatment plan. If we were looking at CBT and graded exposure, the link worker could act on it in the community to support them. For example, if we set the goal of going to baby groups, she could scaffold them to do that. Not much of their lives are in that hospital appointment, so being able to have that holistic picture and that community support is invaluable. And then this last quote, just thinking about that co-production of outcomes with mums in service delivery. When I felt no hope, she's always been on the end of the phone. She listens, she understands, she doesn't judge. She got us a food parcel, put me in touch with a charity who provided baby milk and nappies and baby clothes. I could free up money to put the little one into childcare, to give me time to help myself. I'm looking now at going to college this year. She got the details and asked if I'd like her to go along to the open evening with me. I don't think I could have done it without support. I didn't think I'd be able to go back to college. She made us feel more confident, knowing that I can do that. And I think that's something that we've heard really consistently from women. And I think one of the things that I've really valued about the link worker learning community has been that we have been able to gather these really rich case studies and rich stories from mums demonstrating the value of the service and the difference that it makes. So next steps for us, we are about to complete our final evaluation of this work. We did an interim evaluation about this time last year, and I think it's fair to say we feel we've developed a really strong service model, and we've had the last 12 months to really be able to test and refine that model. We've also been doing some development work with an organisation called Including Men. And I think one of the things that we heard really strongly through the lifetime of this project was, what about fathers and partners and what about their needs during the perinatal period? So we've been doing a piece of development work with Including Men, looking at a bit of an action research project, kind of taking the things that the link workers have been hearing and seeing from working alongside women and families, where women have really said, actually, this support around maternal mental health has been great, but my partner could also really use some support. And we've been doing some signposting around that, but this was about really understanding what that need is during the perinatal period. And then finally exploring potential for scale and spread. So we're currently funded to develop this work up until the end of September 2024. We're really actively in that kind of cycling phase of thinking about scale and spread and how we could potentially scale this model. And really look forward to building on the learning that we've been doing over the last couple of years and hopefully being able to continue to deliver this really good work. So I'll stop there. Thank you very much for inviting me to share some of this learning with you today.
Thanks, Ange. That's really great examples there of social prescribing and co-production. And we've got time now for any questions or comments that people might want to raise. If you want to put your hand up or put a question in the chat, that'll be fine. Andrew, I don't know if you can see any.
I'm just having a look through. I can see comments in the chat, but I can't see any direct questions.
No. Okay. Can I ask one then, since I haven't got any coming through? I'm just interested to know. I mean, I've just come from a meeting about creative help. So I think it's interesting that you've been using those creative methods. Is there anything come out that's kind of surprised you, or you think it's kind of something you hadn't expected?
From the creative approaches, particularly.
From the project more generally.
I think when we set this up, Richard, we knew we would be working around mild to moderate mental health needs, but I don't think we quite estimated the level of complexity that we'd be working with in terms of supporting women with those needs. So I think this project was just kind of getting off the ground, and then we'd had COVID hit, and then the cost of living crisis, as that's really bitten. So I guess neither of those things are surprises, but both of those things have had quite a big impact on how the work has been delivered, and I think how the work has been experienced by women. And I think we were hearing that, you know, midwifery and health visiting were not continue to be really, really overstretched. And the work that the link workers have been able to do to support women to access food banks and baby banks has been really valuable. And I think what we've really seen there is that through being able to be supported by the link workers to access those things, women have been better able to engage with more of the statutory support. So that might be about being on the waiting list for token therapies, and then when your appointment comes along, because you've dealt with all of the kind of practical challenges and the financial challenges, women being much better able to respond with that therapeutic intervention. So I think there's some of the things that we've learned along the way, and we're able to really demonstrate the effectiveness of the link work support, both for the women but also the impact on the wider system too.
It's that holistic approach.
Sorry, there's just another question has just dropped into the chat from Lynn. So did you support the project with a lot of funding, or was it just the cost of the link worker?
It was the cost of the link worker. We had some funding internally, or kind of centrally, I suppose, within Ways to Wellness to bring the link workers together for any training needs that they had. So as we were getting the project set up, we found that we could smooth that process, I suppose, of integration with the health system if we looked at training for the link workers around perinatal mental health. So we looked at a Tavistock and Portman training course, a 20-hour training course, and being able to commission that kind of centrally across the projects was really effective and much more cost effective to do it that way. And we also had some central funding to look at a monitoring and information system for the project, and that's been really instrumental in gathering our learning together. So the funding that went into the prototype providers was for the cost of the link worker and also the cost of the peer supports, and that's been different in each area. So for the chat and chai group, that's been about supporting the cost of room hire, but for the Northumberland project, that was about the costs of a DBS check and room costs and a few other things in there too. So I think really valuable being able to have that flexible approach to use of that funding, and then be really responsive to the things that the link workers needed. So if we identified that there was a training need, as we did around looking at birth trauma, we were able to commission some specialist training there too. I can see that there is another question, but I cannot see the chat.
All right, if we've got time just for this last one then. So Lisa's just saying, love that the link workers was being supported as lone workers through the project. Will they continue to receive ongoing support and mentoring, and who provides this? Mental health professionals, etc.
Yeah, that's a bit of a mix, I guess, because we have 4 different providers who can draw on different things, but we will continue to provide the link worker learning community for the lifetime of the project and potentially beyond. One of our services has been successful at securing future funding for the next 12 months, so we'd be keen to continue that learning community approach. And I think certainly the support that we've been able to call on from academic partners and things, we hope that we'll be able to continue beyond the lifetime of that project. And then from a link worker learning perspective, different in each of the areas, but each of the link workers receive supervision. In some cases, that's clinical supervision within the organisation, and in some cases, that's supervision within the wider maternity and healthcare system. And I think, again, that's been really instrumental in moving from this being a small project based in the VCSE to feeling much more integrated within the wider maternity system too.
There's just one more. The questions are popping in. So if you just want to answer this one and then maybe pick up any of the others in the chat, just so we give Lorna enough time. So Charlotte's just asking, how do you build in co-production in that very early fuzzy phase?
That's a nice question. One of the things that we decided to do quite early on was to start to bring people together across the system, so mums, but also professionals across the system, because as I said, social prescribing was feeling really quite new for midwives and health visitors and for some of the health professions that we were associated with. So we started to use a space in the centre of Newcastle, the Lytton Phil, to bring people together once a quarter, both across the system and women with experience of using services, to really look at the really early trends and themes that the link workers were seeing and hearing on the project, and be able to explore some of those things together. That was a real critical friend approach. There were some things that we were trying that maybe didn't feel quite right either to the system or didn't feel quite right to the women. So having that really open space early on to be able to have those conversations, unpack things, and like I say, to sort of pivot and change direction if something wasn't working was really valuable. And I think just starting with those principles, really, that were really open principles, but were about just us being very open to learning, and that if we identified something that wasn't working, we wouldn't keep going with that. We would shift and change, felt really important, and I think people were very responsive to that.
That's great. Thank you for that and for answering those questions. And we've got to move on. So thanks, Ange. And if you do think of other questions, then drop them in the chat. And I'm sure Ange doesn't mind sharing her contact details as well. Okay, so our next speaker is Lorna Dawson from Sunderland South Shields Healthcare Trust, and she's going to tell us about their work on health literacy and involving and engaging people in that work.
Thanks, Richard. I'm just getting my presentation up now. People might have had a sneak peek at how to plan their leaflet, which is not what I'm going to talk about. There we go. So can people see South Tyne Sunderland community? Yes, I can see a thumbs up. Thank you. Yep. So yeah, thanks very much for having me. My name's Lorna Dawson. I'm the Health Literacy Officer at South Tyneside and Sunderland NHS Foundation Trust. And I also work 1 day a week with the ICS Health Literacy programme too. And I'm going to talk about, but I've got my I've got both hats on today. But I'm going to talk about kind of how, as a trust, we delivered or didn't deliver on that ICS principles of kind of working together. So first of all, I'm just going to kind of go through in a little bit more detail the ways of working or the principles that Becky kind of introduced you to. And then what I'm going to do is kind of talk about what we did in our community engagement in South Tyneside and Sunderland, and how well did we manage to kind of follow those principles. So it's a bit like marking our own work. So I have to say that our community engagement kind of came before the principles, not as a defence. I think it's interesting to see it and to mark it. So I've kind of reworded the principles slightly, just how we would do it, almost like in a really basic health literacy way. So I've made them really simple. So when we work with people, we make sure that we think about what's best for people. And we make sure that people are part of decisions that affect them. So the stuff's not done just to them. And the way that we do this is we do this by listening to people. So who do we listen to? So we try to listen to everyone in the community, and that includes kind of marginalised groups. How do we listen? We listen in lots of different ways, and we try to ask Health Watch and the voluntary and community sector to help us do that. And then in terms of when do we listen, we try to listen basically all the time. So before we start, while we're working, and then after we finished. So the listening doesn't stop kind of just because the work's done kind of thing, and we try and get people in there before we actually do the work to make sure it's right. What kind of things are we listening for? We try and listen for what's working well, what's not working well. We ask for ideas on what people would like to see. We ask people what's like important to get changed, and also whether we've made a difference. So that's that listening kind of after we've finished. And then what do we actually do with what we've listened to and what we've heard? So we try and build on what's good, so what's already there being done and what's working well. We share information that's clear and easy to understand. We help communities to help themselves, so that kind of like asset building. And we also try and connect people who are doing similar work. So that is a very whistle-stop tour of the principles. Now what I'm going to do is just explain what we did at the Trust, what we did with our community engagement, and how well we kind of did those different things. So what were we doing at the Trust? So we say that our average local reading age is about 9 to 11, but we did an audit of all our patient information leaflets in the Trust, and over 90% of them weren't written at that reading age, they were higher. So they're written in a way that's kind of more complicated than we think the average person can read and understand. So what we said we would do was rewrite those leaflets at a reading age of 9 to 11. And there are kind of like almost 900 of them that we had to do. And kind of like we were doing this because writing information, people's health information in a complicated way makes it harder for them to be involved in their own care. So by writing in a slightly different way, we were trying to do what's best for people, by getting them kind of making it easier for them to understand. Yeah, so they can make kind of more informed decisions about their health. They can be empowered to take charge of their health. So that's what we thought we were doing in terms of like making sure we think about what's best for people. So I think empowerment is really important. But then we kind of needed to test out whether writing at that reading age of 9 to 11 was okay. So really it's best practice if you're writing stuff for people to kind of write it with them and involve them from the start. But our project, like we were kind of changing 900 leaflets. So before we made a change to that amount of stuff, we did need to check that writing at a reading age of 9 to 11 was understandable. Because if it was, because that statistic is based on estimate. So we haven't gone out and tested the reading age of local people. It's kind of based on demographics of the local area and statistics and stuff like that. So to be absolutely sure, we wanted to kind of check that was right and that it was understandable and that actually we didn't need to write at an even lower reading age. But kind of that was a decision, and we wanted that was a decision that we'd said we think the the average reading age is this, but people hadn't kind of told us that. So people weren't part of the decision at that point. So we needed to kind of like give them a voice before we made such a massive change. And we had to go out and see people to be able to do this, so to listen to people. And this was kind of like showing how we're listening before we started. So before we actually made that massive change, we were listening to people and checking. So some of the key principles are listening to everyone in the community, including marginalised groups, and asking Health Watch and like the BCSE sector to help us listen. And the people who are most affected by health literacy are kind of people from the most deprived areas. They're people who are often marginalised. They might be from kind of, yeah, ethnically marginalised groups, for example, they're also not the people that we usually hear from. So we really wanted to hear from kind of those people. And there are lots of reasons why we don't kind of like usually hear from them. Might be if you set up kind of like a focus group for people to come, it's like people have other priorities. Like if they've got to choose between kind of going to your focus group and getting the shopping, they're going to get the shopping. So we had to kind of think about that, and that really affected how influenced our approach. So we didn't ask people to come to us, we went out to them. So we went out to community groups, and we asked kind of Health Watch, and we did get massive support from like Health Watch and the local community and voluntary sector to be able to go to groups that were already happening, because if groups were already happening, people were likely to be there. We also went to a lot of warm spaces. So because we thought people who were struggling to kind of like pay their bills, or kind of cost of living crisis to heat their homes, they'd be likely to go to these places. So we targeted kind of like the warm spaces, because we thought more deprived people would be there. And we also tried to match who we spoke to local demographics. So about 50% of South Tyneside and Sunderland live in the top 20% most deprived areas in the country. So we used kind of like postcodes to target groups in the most deprived areas to try and see kind of, that 50% of people. And I think that's something that worked really well. So 50% of the people that we did actually speak to came from the most deprived areas, so we matched that up quite nicely. Then in terms of like how we did our community engagement, I say this is kind of like where we vary from the kind of principles a bit. So the principles are, what are we listening for? Like what's working well, what's not working well, ideas on what people would like to see, what's important to get changed, and whether we have made a difference. But as I said earlier, we were kind of going with an idea in mind that we think we need to write at a reading age of 9 to 11. Is that right? So we were kind of like looking for permission and confirmation. It was a bit less exploratory. But that's not to say, so we showed people a leaflet written at a reading age of 9 to 11, so we could say, is this working well or not? And we did kind of give room for people to kind of comment. So on what's not working well, we had a lot of people complaining about the health service, which is fine. And kind of like just listening to people and allowing space for those comments did open up more kind of thing. But we were asking things about like how the leaflets looked, because we didn't think that was working so well, and if people could understand them. We also asked if the way they were written made people feel talked down to or offended, because a lot of staff were worried that writing at a reading age of 9 to 11 was patronising. And we kind of asked if anything was missing. So I'd say we kind of like deviated a bit there. And we also deviated in how we listened. So the principle is we listen in lots of different ways. So we just went out to people and spoke to them in person. We didn't use digital or an online survey at all. The reason we did this was because we didn't want to exclude people who didn't have access to the internet. But we could have had like a bigger reach if we had used digital. And I think so. The people that we did spoke to, and this is a massive generalization, so we didn't speak to very many people in like younger age brackets, so like teens, or 20 to 30, and I don't know if we'd kind of like done an online survey, and we were going out during the day. I don't know if we'd done an online survey, we might have captured more of those demographics. Again, that's a very sweeping statement, but kind of again, so we were looking for the most deprived people, and people like in deprived areas are probably less likely to be able to access the internet. So the other reason that we did it was because we started with a little choice experiment of, do you like this leaflet or this leaflet? And they looked slightly different. So one was A4 and one was A5, and you couldn't really do that online. But if you're just checking the way something is written, so whether it's understandable or not, you probably could use online a lot more. But one of the things we did do is we tried to listen without making people feel judged. And I think we did that quite well. Because it's very easy to go in and say, oh, I've changed this, and people, because you come from the NHS, people don't want to say, oh, you've done a bad job, or they do. But kind of like sometimes people you see somebody laughing. Yeah, they don't want to tell you that, oh, you've worked really hard on this and I'm going to tell you that it's rubbish. So what we did was we went in and said, look, we've tried to change things, but we don't know whether we've done well. Please, can you help us? And kind of said, look, you can say anything. And I think that did help a lot. Try and speed up. So what are we doing with what we've heard? So the principles are building on what's good, sharing information that's clear and easy to understand, helping communities to help themselves, and connecting people who are doing similar work. So I think we are kind of like definitely sharing information that's clear and easy to understand. So we are rewriting information at our reading age of 9 to 11, and the response has been very positive. And in terms of kind of like, and I think that will help people to help themselves if they can understand information easier. And in terms of like connecting people or helping them to build on what we've done, is we're making writing guides to try and share with people. We're part of this like regional health literacy work now. So the team at the Trust here has trained the writers for the ICS team. So we are trying to kind of like share what we're doing slowly but surely. And then, have you finished your community engagement now? So one of the principles was we listen before we start, while we're working, and after we've finished. So we're still working on the leaflets at the moment. We are coming towards the end, which is great. But so what we're doing now is kind of monthly community engagement. So it's still like 900 leaflets. We can't check every one, but we're doing almost like a temperature check. So we take a few out every month and check that the way we're writing is still okay. And then in terms of listening after we've finished, we are evaluating the work to see if it's helped. So again, that's going on at the moment. So we're checking with staff and with the public to see if this does make a difference to kind of like understandability. Do people feel more empowered to challenge? Does it affect people's attendance? Because that was one of the things that health literacy is supposed to affect more people. People with lower health literacy are more likely to not attend appointments. So we're kind of listening while we're finishing as well. So hopefully that gives you an idea of how we've like matched up. So it's not perfect, and I don't think it ever will be, kind of thing. Because yeah, as Richard said, we're kind of like starting things off and leading the way, but we're not perfect either. We're learning things as we go. But if you want to find out more, we've got a general email address, or that's my email address as well. So yeah, thank you. I've not been watching the chat.
Thanks, Lorna. That's fine. Yeah, we've still got time for any questions that we might have. Anybody got a question?
I can see in the chat, Rachel's asked about accessing the regional health literacy training. So there is a regional health literacy website, which I'll find and post a link to. So there's not any training being run at the moment, but they are. We've got 2 trainers in post, and they'll be setting up monthly workshops. I think it'll be within the next couple of months. But you can always kind of like get in touch and see if they can send you anything. So I'll send you, I'll put the link to the ICS webpage in the chat, and I can pass on your details to the trainers and ask about what else they can offer.
And I think eventually this will be, training opportunities will be housed on the Health Equity Learning Academy site.
Yeah,
which
yeah.
will be accessed through Booster on it. So
Yeah.
yeah. anything else? No, okay, we've got a few minutes left. Thank you, Lorna. Really interesting kind of drawing the kind of common threads from those two examples of co-production in practice. And I think the things that stood out for me are that need to listen and really listen before you start, and through the process and afterwards, and then be flexible and I think it's partly about, it's all about giving up power, you know, and as professionals don't always want to do that, but it's about saying that no, we haven't necessarily got the right answers, despite what we might think, and we have to be willing to flex and respond to what people really need. I'm just going to finish with a couple of slides. Just catch up with where we are. We've got a feedback questionnaire, but I'm going to just skip through to resources first.
That's showing now, Richard.
Thank you. So there are loads of resources. You know, you just have to Google co-production guidance, etc., and you will get loads. So I've just put a few on here to get you started. There are some really helpful guides here, and toolkits, and particularly I would flag the Research Engagement Network toolkit and guidelines, which have been developed to help organisations that want to engage with communities and guide on how to do that, because you know, we do see some poor examples of organisations that where it can feel a little bit kind of extractive and people want to come in and kind of get lots of information from people, and without doing the hard work beforehand of developing relationships and thinking about the needs of those people. And so I think that's really helpful guidelines there, but there are plenty more available. And if you would like to know more about this work, about our programme in more generally healthy communities and social prescribing, we're part of the ICB funded Healthier and Fairer programme, then you can find that on our website, and you can join our Healthy Communities and Social Prescribing Network. That we'll send you bulletins, keep you updated, let you know about further training opportunities, etc. Sorry, Tom, if I'm jumping around. I think the last thing, apart from thanking the speakers again for doing an excellent job of explaining their work and how they put co-production in practice, there is a little survey, if you wouldn't mind letting us know, because we're really keen to develop more of these, and we'd like to hear from you as to what topics you think would be particularly interesting and useful to you. So if you wouldn't mind taking part. Thomas, the link in the chat, or?
Yeah, I've just dropped that into the chat. There's the SurveyMonkey link.
And it will literally take you a minute or so. While you do that, is there anybody who wants to make any final comments or questions? No, we all done. Okay. Well, thanks everyone for coming, and yeah, do get in touch if you think of any other questions afterwards. And hopefully we'll see you at a future webinar.